Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month online in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I am here with our podcast editor and my co-host, Josh Berezin.
Hi, Lisa.
Hi, Josh. Did you have a nice New Year?
I had a pretty nice New Year. Still recovering from the freezing cold temperatures.
It is so darn cold.
Yeah.
Well, it's nice that we're in here and keeping warm, and we are going to be discussing 3 articles. How about that?
Sounds good.
Heard that before?
Yeah.
The first is going to be discharge practices in a supported employment program, individual placement and support, it's called. The second article is going to be focusing on a QI approach to improving use of constant observation in general hospital. And third, we're going to be looking at an article that summarizes and reviews 3 non-traditional approaches to improving psychiatric care.
First up, we have Justin Metcalf, Robert Drake, and Gary Bond on the use of standardized discharge in IPS-supported employment programs. So, Lisa, I know this is a subject that's near and dear to your heart.
Yep.
Can you give us just a quick background on IPS in general?
Sure. IPS, we're talking about individual placement and support, which is a supported employment model that's focused on helping individuals, in this case, who are experiencing serious mental illness, get competitive employment. And there are some key features to IPS. One is that it is fully integrated into the mental health system. You don't have the person's clinical care in one part of town and the vocational service in the other part of town. It also focuses on rapid placement. The idea is that we don't do long periods of
training and
exactly. So
before you go to work, it's like we're getting you into the job market right away.
Work is the best training for work. And there's a number of other features to it, but those are the critical ones. There's a no exclusion policy. Anybody who wants to work can get this. Should be able to get this intervention, and the intervention wouldn't exclude someone on the basis of any particular criteria. They only have to want to work.
So it's like similar to housing first. It's like work first.
Kind of, yeah. In that way.
I think before we dive into what the article actually goes over, the context for it is pretty, I think, important and interesting to understand. So this is really about discharge, but that brings up a whole host of issues.
Right. Yeah. So this article focuses on when should IPS end. Okay.
Seems like it should be a simple answer, but
well, anybody who works in a care delivery where services that have a fixed caseload or require certain resources knows that one of the most difficult things is to know when a service ends. So we're struggling with this whole issue in early psychosis treatment. If we don't have people discharged from the program, we can't take new people into the program, and the same with assertive community treatment. So really, in all services, we have to have an on-ramp and an off-ramp. And so this is a really interesting example of a study that focuses on the off-ramp for individual placement and support. And the article describes the kind of natural state of affairs, which they call attrition in terms of the off-ramp. So it's just people stop when they're ready to stop. That
could be in 2 months, that could be in 9 months, that could be in 18 months when they get a job or when they're disengaged. Right.
It's kind of not specified in the model.
Right.
It's natural attrition. The setup of the article invokes the contrast between natural attrition and something that they called IPS light. And in this case, in implementing IPS light, if a person didn't work, had no competitive job for 9 months, they're out. That's discharge. Or if they have competitive work for 4 months, they're discharged. So if they quote unquote fail or succeed, that's the time that discharge would occur.
So it's set.
Yeah, exactly. It's not just natural attrition. The notion of discharge at 9 months without work or 4 months with work is kind of an alternative way to establish when the off-ramp should be.
Got it. And so what this study is doing in particular is seeing if IPS might actually be beneficial beyond that 9-month cutoff.
Exactly.
They used data from the mental health treatment study, which is a 2-year randomized controlled trial, 23 sites, 2,055 participants in the final analysis that they used. So these are people who are on SSDI, they have a diagnosis of schizophrenia or mood disorder, and they haven't worked in the last 30 days. So the intervention of this study was IPS, it was medication management, and it was other behavioral health services, and it was compared to treatment as usual. So what they had during the study is that people would self-report their employment every 3 months, and this is the data that the authors are looking at, and they're trying to find how long it takes to get to the first job, or how many people get a first job in a certain amount of time, and then the probability that a participant would find a job in any given quarter.
Exactly, and it's important to note that this is a very famous study, the mental health treatment study, and this is a secondary analysis of those data.
So what they found is that in both groups, the likelihood of finding a first job declined over time, but the IPS group was more likely to find a first job for at least 18 months. And just to make that concrete, in months 9 through 18, the group that was getting IPS had 62 more first jobs, even though that group had a smaller sample size.
Yeah, so what they found was that people are getting more jobs after the 9-month cutoff.
And so that has real implications for how you run the program.
It sure does. It gives us data to think about. We do know that people are more likely to get jobs, on the front end of the intervention. But then at what point do you say, well, we can't keep this going forever. We'll get benefit, but the benefit's going to get smaller over time.
Yeah, but at least this lets you weigh kind of like the pros and cons, right?
Exactly. And I think they've demonstrated that there is persistent benefit and advantage for the intervention after 9 months. And so if we stop it at 9 months, then certain people are not going to fully realize the potential benefit of the program.
I think what's cool about it is that they're actually able to put some numbers to this. They're actually able to study it. And also that I think, we think a lot about how programs start, the on-ramp and getting people onto programs and what the actual intervention is, but we don't think quite as much about getting people off when it's the right time to end.
Exactly. This is a great example of a study that focuses on a really important question of an implementation question for service delivery.
Next up, we have Aaron Pinkasoff, Deepan Singh, Sridivya Chavali, and Lori Legrand on a proactive behavioral health service model to address use of constant observation in a general hospital. So I think there's two kind of broad points of background here. One is this broader move in healthcare towards value, right, which is high quality at low cost.
Yeah, and as a matter of fact, this paper is in our value in healthcare column.
Oh, well, that's aptly placed. But the other one, the other kind of bit of context, which I really like about I like that the paper merges these two things, is how do you establish a presence for a psychiatry service at a general hospital that doesn't have an inpatient psychiatric ward?
Yeah, so it gets us into this theme of integration, care integration.
Yeah. And then the third thing is that specifically we're going to talk about...
I think we only said there were two things.
Okay, fine. So the second and a half thing is the use of constant observation. So constant observation in this setting is when somebody on a medical ward needs to have like a one-to-one or some sort of... I'm trying to define it without using the words constant observation, but somebody watching. Yeah, and like I think the thing to think about for this particular paper is people with delirium or dementia. I think this is really geared towards what.
It's not just sort of someone who on psych we think, the person's suicidal, or this is someone. This focuses on people who may end up hurting themselves because of delirium.
Right. This is a report on a QI initiative that was geared at those 2.5 to 3 points that I mentioned before. This is a psychiatry service at New York City area hospital with 591 medical and general surgery beds. And again, no psychiatric inpatient unit. When they took a look at constant observation in the hospital, they found it was pretty high cost. It was $2.3 million a year that it was costing the hospital, but it wasn't really improving outcomes.
Yeah, so you have a great sort of target for quality improvement. High cost, low yield. And I think the other point that's so compelling for me about this is that this project wasn't done by researchers with NIH grants. This was done in a general hospital by administrative and clinical leadership to make things better. And one of the reasons that I wanted to discuss this was so that our readership and the listeners here could see this as an example of what clinicians and clinician administrators can do in actual practice to make things better.
You can try this at home.
There you go.
And the other thing to encourage is that when you do something innovative, submit it, because you can really affect care in the rest of the country. So here's what they did: is they came up with essentially a pre and post design. They looked at a 6-month period of trying a new approach to constant observation, and then compared it with aggregate data on patients who had gotten continuous patient observation in the prior year. The first thing they did when they're thinking about this project is they brought in stakeholders from the hospital, so nursing, the hospital QI department, and they actually ended up getting a lot of support from those other parts of the hospital.
Yeah. They got support not only in implementing the program, but they also got a lot of know-how and expertise.
Because they sat down and actually talked about these specific scenarios about why people need constant observation, how it's working in the hospital, things like that. And what they ended up doing is developing a protocol that, first of all, included a formal psychiatric evaluation within 24 hours for anybody who had a constant observation order. And then they developed a subsequent protocol for people with delirium or dementia that included interventions like increasing activity, helping people be comfortable, and then addressing environmental risk factors for delirium.
And a nurse practitioner implemented this in conjunction with a board-certified psychiatrist. So they had the protocol and then they had the staffing.
Yeah, so that's the team. And we should also mention that they discouraged use of benzos and opiates and other anticholinergic medications that can exacerbate delirium. So here are the results. When they looked at this group of patients who had this new protocol, there were a few patients who actually needed immediate transfer to psychiatry. But again, the bulk of people we're talking about are people who have dementia or delirium. So when they tried this new protocol, the costs were actually 33% lower. The length of stay was 15% shorter, and they estimated about $750,000 in savings.
Yeah, pretty good.
Pretty good, right? In the period prior to initiating this new protocol, there were 63 falls for a similar patient population, but after they initiated it, there were just 2.
Which is very impressive. Now, it may well be that the interval was different, that the prior was a year, and the study period was 6 months, but still the difference between 63 and 2.
Yeah, even if you
could double or triple or quadruple. Well, 2 to the what is 64? What is?
I don't know. This is not a math podcast.
They had a lot fewer falls.
Yeah, okay, I want to say 4, but anyway, we'll check that later. So it also made a dent in prescribing practices. So during the intervention, about half of people on benzodiazepines had them discontinued, and about the same number with people who are on opioid medications as well.
So this was I think this was a really impressive project, very, I think something that other hospitals can learn from, and, using a thorough, well-considered QI methodology that allows, it's some inferences. Now it's not a randomized trial. It's not like we had, 10 hospitals or 20 hospitals doing it and comparing it to 20 hospitals that didn't. But in the context of the real world, the need to make change and to improve care, this was pretty darn good.
And it also was a way for that psychiatry department to become a real part of the hospital, which I think will probably have implications for the rest of their service and helping people with other problems besides this constant observation issue.
Yeah, it's almost like they became players.
Yeah. Last up, we have Kieran Grant, Magenta Bender-Simmons, and Christopher Davey on 3 non-traditional approaches to improving the capacity, accessibility, and quality of mental health services. An overview.
That's a mouthful.
It's a mouthful, but these are 3 kind of large interventions that they're talking about.
It's a big paper. It has a lot of scope.
Yes, wide scope. We're not going to get into every details. We'll try to give an overview of the overview.
Yes.
So the context here is, I think, as most of our listeners know, that there's globally a growing need for mental health services. One statistic that they point out is that the World Health Organization's estimate that by 2030, unipolar depression is going to be the most burdensome illness in the world. So high burden of illness, and then also a shortage of providers. Won't be a surprise either to any of our listeners. The statistic they point out here is that 75% of U.S. counties have severe shortages of mental health service providers.
Any of our listeners who are involved in service delivery knows how hard it is, virtually, in many, many places, if not most places, to get providers.
Right. And even in places that are provider rich, like where we are in freezing cold New York City, there's pockets where it's very difficult to get providers in the public mental health sector. So added to this, we've got stigma, we've got funding constraints, and really the combination of all those things means that we're going to have to look to non-traditional approaches to providing care for the population. So what this paper does, it looks at the research on 3 important and really widespread of these approaches that are kind of expanding our provider base into the community. So those are peer support worker programs, task shifting and task sharing, and then mental health first aid and community initiative programs. So I think most people are probably familiar with peer support programs, at least in the concept, but these are people who have lived experience, who are working either independently or alongside other care providers, who are supporting people who are dealing with a mental illness, which has become a real key part of our service delivery in the past.
Absolutely. So peer support workers are really taking hold all over the U.S. and other areas of the globe.
Yeah, and maybe less familiar is this idea of task shifting, which allows people who are not specialists to do basic tasks. And so the specialists can see more people and they can deal with more complex cases.
Yeah, there's this notion of having people work at the peak of their scope of practice. And so you don't want someone with a very advanced license like a physician or a psychologist or a nurse necessarily doing tasks that could be done by somebody, frankly, who's less expensive and who has less training and education.
So that's task shifting, which is also called task sharing as well sometimes. Then the last approach I'd look at is mental health first aid, and then also similar community initiative programs. So it's a real kind of analogous to medical first aid. People are trained to give immediate assistance to somebody who's in a crisis until they can have a professional kind of step in and help. So this is all about early intervention, improving mental health literacy, reducing stigma, encouraging people to seek help.
Exactly.
Let's go over the key findings. And we're not going to be able to go sort of study by study that they cite, but again, kind of give a general idea. For peer services, it seems that if you add peers to existing teams or have them do case management, it's generally equal to work that non-peers do, and sometimes is slightly better. Again, it's a little bit hard to generalize because the outcomes are so different, like between symptom reduction, homelessness, quality of life, service use, engagement. But it does seem like they're either equal or, in some studies, slightly better.
Yeah, and again, we don't want anybody to mistake the summary of these findings for a statement that having peers do this or having task shifting or evidence-based practices or approaches, we're not at that level or that granular level. But the studies or the summary does point to no worse, if not in many cases, better outcomes when peer support workers are involved.
So for task shifting, most of the research they're citing is actually from low and middle income countries. And it might help to get like a little bit of a sense of what sorts of things people are being trained to do, being trained to take on.
Yeah, so community members have been trained to provide crisis response, case management, and various kinds of outreach services. They were also trained to assist healthcare professionals in a variety of different interventions, including services for mothers with peripartum depression. So really getting into some specific interventions.
And just generalizing across the studies, there's basically positive outcomes across this wide array of settings and interventions, including things like how fast people recover, symptoms of depression, disability.
And really depending on what the task-shifting intervention was intending to do, there were, and again, highly variable studies across the globe, but again, a positive outcomes for given studies.
Right, and similarly, the mental health first aid and community initiatives have sort of like a wide array of settings and interventions, but essentially, they say that there was consistently shown to reduce stigma, increase recognition and awareness of mental health issues, and encourage people to seek help. And they cite a meta-analysis of 15 studies for mental health first aid, and they look at the participants of the trainings and say that they have increased knowledge, decreased negative views of mental illness, and they have increased likelihood of supporting others with mental health issues. But it's important to know that there aren't that many randomized controlled trials in this realm.
Yeah, the mental health first aid and other community initiatives are a little bit more challenging to study using rigorous scientific designs, but nevertheless, there's reasonable evidence that they are helpful in their targets, which have to do, again, with increasing awareness, reducing stigma, and increasing help seeking.
Yeah, one of the reasons they're probably hard to study is because they're supposed to be widely disseminated into broad populations. And one of the ideas is that you actually kind of get exponential growth of these interventions as people who are trained can then train somebody else to provide the same service. So what did you find compelling about this study?
Well, I liked how the authors considered each of these three types of interventions at the same time, and it allowed them and us to think about the similarities.
You know, the whole article actually made me think about something that we talked about a couple months ago now on mental health programming in religious congregations. And I think they're both examples of how we just really need to start expanding our concept of who a mental health provider is and how we're going to meet this incredible need for services in the context of a shortage of providers. There's a lot of different ways to sort of creatively deal with this, and the thing I like about this paper is that it brings a lot of them together, so you can look at a few of them at once and really think about that whole. It's almost a new system now.
Exactly. Well, that brings us to the end of today's episode. Now we get to go outside and be freezing cold again.
Oh my gosh.
We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.
Bye-bye.